Dear students, today I am here to explain duodenum. So duodenum is the first and shortest, widest part, and it is the most fixed part of small intestine. So we can see this one is the duodenum. So it is a C-shaped course around the head of the pancreas. It begins at the pylorus and ends at the duodenal flexure. So here the stomach is removed. So the cut part is the pyloric end of duodenum. So that is the pylorus continues as duodenum. And distally it continues at duodenal flexure as jejunum. And duodenum lays above the level of umbilicus opposite to second and third lumbar vertebra, L2 and L3 lumbar vertebra. So the size of it, approximately it is around 10 inches, that is around 25 centimeters long, and most of the duodenum is retroperitoneal and fixed by the peritoneum to the structures on the posterior abdominal wall. Parts of the duodenum, first part is the superior part. So it has got the first part. Second part is the descending part. Second part. Third part is the horizontal part. Third part. And fourth part is the ascending part. So the fourth part continues at the duodenal flexure. So fourth part is covered by superior mesenteric vessels here. So the fourth part is hiding below these vessels. So these are the four parts of duodenum. So the superior first part, it is the short and it is of around 5 centimeters or 2 inches in length. So this is the first part, and it lies anterolateral to the body of L1 vertebra. So we can see it lies anterolateral to the body of L1 vertebra. The first 2 centimeters of the superior part of duodenum, which is immediately distal to the pylorus, is known as ampulla or duodenal cap and has the mesentery and it is mobile. So it is a peritoneal part. So the first half of the first part, that is first 2 centimeters, proximal 2 centimeters, it is connected to the mesentery and along with the mesentery of the pylorus, and it is mobile part. So this first part is called as, that is the initial part of the first part is called as duodenal cap. The distal 3 centimeters of the first part, that is the superior part, have no mesentery and is immobile. The superior part begins at the pylorus and goes backwards and towards the right and end in superior duodenal flexure. So this is the superior duodenal flexure. Where we can see the first part turns to form the second part. So I will just repeat the peritoneal relations. The proximal 2 centimeters of the superior part is attached to the lesser omentum above and greater omentum below, and it is intraperitoneal and it is suspended by the mesentery and it is mobile. And distal 3 centimeters is retroperitoneal and fixed with the anterior surface covered with peritoneum. So let's see the visceral relations of the first part. Anteriorly, it is related to quadrate lobe of liver. So this is quadrate lobe of liver, which is reflected to expose the first part, that is the superior part of duodenum. And posteriorly, it is related to gastroduodenal artery. So here is the gastroduodenal artery, and posteriorly it is also related to bile duct and portal vein. And superiorly it is related to epiploic foramen, and inferiorly it is related to head and neck of pancreas. This is head and this is the neck of pancreas. So the second part is the descending part. It is around 7.5 centimeters longer and descends along the right side of L1 to L3. So L1, L2 and L3. So it is on the right side of L1, L2, L3 and runs inferiorly, curving around the head of the pancreas. So we can see the second part, winding round, descending part, curving around the head of the pancreas. It begins at the superior duodenal flexure. So this is the superior duodenal flexure. And passes downwards towards the lower part continues with the third part at inferior duodenal flexure. So the second part of duodenum, it is retroperitoneal and it is fixed, and in the middle of the anterior surface it is directly related to the colon, where the rest of the anterior surface is covered by the parietal peritoneum. Visceral relations. Anteriorly it is related to right lobe of liver. So here liver is removed. So the anteriorly it is related to right lobe of liver, and anteriorly it is related to transverse colon, root of transverse mesocolon and small intestine. Posteriorly it is related to medial border of anterior surface of right kidney. So we can see the right kidney here. So the medial border of the right kidney, and it is posteriorly related to right renal vessels. So here the duodenum and pancreas is removed, showing the posterior relations of the second part. So posteriorly it is related to the right kidney and it is related to right renal vessels, which includes both renal artery and renal vein, and it is related to right edge of inferior vena cava. So this is inferior vena cava. So the right edge of inferior vena cava and right psoas major muscle. So these are the posterior relations of the second part of duodenum. Medially it is related to head of pancreas and bile duct. So we can see the head of pancreas and which is along with the bile duct within it. Laterally it is related to right colic flexure. So laterally it is related to the right colic flexure of colon, which turns to form horizontal or transverse colon. Major duodenal papilla. It is a posteromedial elevation present around 8 to 10 centimeters distal to the pylorus. So here is the pyloric sphincter and pyloric end of stomach. So from here, if we take around 8 to 10 centimeters, we can see an opening in the second part of duodenum, which is called as major duodenal papilla. So it is where the hepatopancreatic ampulla opens, and a longitudinal fold known as plica longitudinalis is present below the major duodenal papilla. So the mucosal fold which is around this major duodenal papilla, which is a longitudinal fold present below this major duodenal papilla, is called as plica longitudinalis. Minor duodenal papilla. It is an opening of accessory pancreatic duct and it lies 6 to 8 centimeters distal to pylorus. The next is the third part of duodenum. So here is the third part of duodenum, which is an horizontal part of duodenum. It is 6 to 8 centimeters long at the level of L3 vertebra. So lumbar third vertebra, it is related, and it begins at the right end of lower border of L3 and passes horizontally and ends by joining to the fourth part of duodenum. So peritoneal relations of the third part of duodenum, it is also a retroperitoneal part of duodenum and it is fixed. The anterior surface of the inferior part is covered with peritoneum, and except where it is crossed by the superior mesenteric vessels. So here we can see the superior mesenteric vessels, both vein and artery. And also at the root of mesentery. So except those areas, the anterior surface of the inferior part is covered with peritoneum, except it is crossed by the superior mesenteric vessels and root of mesentery. Next, about the visceral relations. Anteriorly, the third part is related to superior mesenteric vessels and root of mesentery. So we can see superior mesenteric vessels in this image. Along with these vessels, there would be root of mesentery as well. Let's see the posterior relations of the third part. It is related to right psoas major. So here is the right psoas major. And it is related to right ureter. So right ureter, which is a continuation of right renal pelvis, and it is also related to inferior vena cava. So here we can see this is inferior vena cava, and it is related to abdominal aorta posteriorly. And it is also related to origin of inferior mesenteric artery. So we can see the inferior mesenteric artery arising from abdominal aorta. We cannot see the origin, but we can see the inferior mesenteric artery below. And it is also related to right testicular or right ovarian arteries. So right testicular, here is the inferior mesenteric artery, and this is the right and left testicular arteries. So it is related to right testicular. So this one is the right testicular. So right gonadal vessels. In females, right ovarian artery is related, and whereas in males, right testicular artery is related to the posterior side of third part of duodenum. And superiorly, the third part is related to the head of pancreas. We can see very well the head of pancreas and along with its uncinate process. And inferiorly, it is related to the coils of small intestine, that is the coils of jejunum. Next, moving on to last part, that is ascending fourth part of duodenum. It is the short 5 centimeters in long, and it begins at the left L3 vertebral level. So we can see begins at the left L3 vertebral level. It ascends up and turns abruptly to form duodenojejunal flexure. So it rises superiorly as far as superior border of L2 vertebra. So we can see the abdominal aorta. So it runs superiorly along the left side of abdominal aorta to reach the inferior border of the body of pancreas, and here it curves anteriorly to join the duodenum at duodenojejunal flexure. And duodenojejunal flexure is supported by the attachment of suspensory muscle of duodenum, which is otherwise called as ligament of Treitz. Suspensory ligament ligament of Treitz or suspensory muscle of duodenum, it is composed of a slip of skeletal muscles from the diaphragm and a fibromuscular band of smooth muscle from the third and fourth parts of duodenum. So, from the third and fourth part of duodenum to the inferior surface of the diaphragm. Like this it would be. So, the connection between the duodenojejunal flexure and the inferior surface of the diaphragm is called as ligament of Treitz. It is composed of a stripped muscle fibers, that is from the upper part it composed of stripped muscles, that is skeletal muscle fibers, and middle part is made up of only elastic fibers, and the lower part consists of plain smooth muscle fibers. So that indicates that upper stripped muscle fibers are from the diaphragm. That is the reason it is made up of skeletal muscle. The middle is just contains only the elastic fibers, where the lower part of ligament of Treitz contains the muscle fibers, that is the smooth muscle fibers, which are derived from the wall of duodenum. So it facilitates the movement of intestinal contents by contraction, which widens the angle of duodenojejunal flexure. Peritoneal relations of last part, that is the fourth part of duodenum, it is mostly retroperitoneal and covered anteriorly with peritoneum. Its terminal part is mobile and it is suspended by the uppermost part of mesentery. Visceral relations, anteriorly it is related to transverse colon, transverse mesocolon, lesser stack, and also it is related to stomach. Posteriorly it is related to left sympathetic chain, then it is related to left renal artery, left gonadal artery, and also inferior mesenteric artery. Superiorly it is related to the body of pancreas, and to the right it is related to attachment of upper part of root of mesentery, and to the left it is related to left kidney and left ureter. So that is about the relations of the third part of the duodenum. Let's see the arterial supply of duodenum. Duodenum is derived from both foregut and midgut. So duodenum is developed from the foregut up to the level of opening of bile duct into the second part of duodenum. So that is almost at the opening of major duodenal papilla. So below the level of major duodenal papilla, it is derived from the midgut. So the part of the duodenum proximal to the entry of bile duct into the descending part of duodenum is supplied by superior pancreatico-duodenal artery, which is a branch of gastro-duodenal artery. So here is the superior pancreatico-duodenal arteries. So which is a branch of gastro-duodenal artery. So the gastro-duodenal artery is a branch of celiac trunk. So superior pancreatico-duodenal artery, we can see it is a branch of gastro-duodenal artery, and gastro-duodenal artery is in turn a branch of celiac trunk, and we already knew that celiac trunk is the artery of foregut. So till the major duodenal papillae, it is supplied by the branches of celiac trunk. And the part of duodenum distal to the entry of bile duct is supplied by inferior pancreatico-duodenal arteries. So inferior pancreatico-duodenal artery, it is a branch of superior mesenteric artery. So we can see these pancreatico-duodenal arteries are dividing into anterior and posterior branches. So we can see the anterior descending pancreatico-duodenal artery and posterior descending pancreatico-duodenal artery from the superior aspect. From inferior also, the inferior pancreatico-duodenal arteries are again splitting into anterior and the posterior branches. Additional supply of the duodenum is to the first part of the duodenum from the right gastric artery. So the right gastric artery also supplies the little first part of duodenum and also supraduodenal artery of Wilkie. Supraduodenal artery of Wilkie, it is a branch of common hepatic artery. So common hepatic artery is again a branch of celiac trunk. And some branches of right gastroepiploic arteries and retroduodenal branches of gastroduodenal artery also supply the duodenum. Venous drainage. Duodenum drains into splenic, superior mesenteric and portal veins. So we can see splenic vein, superior mesenteric vein, portal vein. Lymphatic drainage of duodenum. Most of the lymph from the duodenum drains into pancreatico-duodenal group of lymph nodes. So most of the groups are here. These are all pancreatico-duodenal lymph nodes. Which are along the inside curve of duodenum. So pancreatico-duodenal nodes drains into hepatic nodes. So here are the hepatic nodes. Hepatic nodes are near the common hepatic arteries, and from the hepatic nodes the lymph drains into celiac and superior mesenteric nodes. So I just repeat, pancreatico-duodenal nodes principally drain from the duodenum, which are along the inside curve of duodenum, and these pancreatico-duodenal lymph nodes further drain into hepatic nodes, which drain into celiac nodes, and the lower part of pancreatico-duodenal lymph nodes drain into superior mesenteric nodes, and these nodes drain into intestinal trunk. So finally all the nodes drain into intestinal trunk and cisterna chyli, and which ascends up as the thoracic duct. Nerve supply of duodenum. It is supplied by sympathetic and parasympathetic nerves. So sympathetic nerve supply is from T9 to T10 segments. So T9 and T10 segments supplies the sympathetic supply, whereas the parasympathetic is by vagus nerve, which forms a celiac plexus. So these nerves innervate the duodenum. Histology of duodenum. The mucosa consists of simple columnar epithelium, which is called lamina epithelialis, and a connective tissue layer just below the epithelium called as lamina propria, and a smooth muscle layer which is called as lamina muscularis or muscularis mucosa. The intestinal epithelial cells are called as enterocytes and are overlaid by a layer of glycoproteins and mucin. The submucosa comprises of loose connective tissue, numerous blood vessels and Meissner's plexus. A special characteristic feature of duodenum is the Brunner glands. Brunner glands are embedded in the submucosa, and these produce mucus secreting bicarbonate ions which serve to neutralize the gastric acid. So the food which is already acidic in the stomach, when it enters into the duodenum, it gets neutralized because of the secretions of Brunner glands. And these Brunner glands secrete alkaline secretions, which appear to be like a mucus glands, and they are present in the submucosa, which is an important characteristic feature of duodenum in histology. And furthermore, the crepes of Lieberkühn lie between the villi, and Paneth cells are found in the lumen of these crepes, and it is believed that the Paneth cells play a role in antimicrobial defense. However, their functions are not fully understood yet. The outermost layer is the muscular layer. So, the muscularis consists of an inner circular and outer longitudinal musculature, between which there are nerve plexus called as Auerbach's plexus. The duodenum is rich in absorbing enterocytes, mucus producing goblet cells, and peptide hormone producing endocrine cells. So, these are the cells which are present in duodenum. Clinical significance: inflammatory erosions of duodenal mucosa results in ulcers, and most common cause of that is herpes pylori, but it is also caused by stress, acid and pepsin. And most common site of ulceration of duodenum is the posterior wall of the first part of duodenum, due to direct exposure of this part to the acidic contents reaching from the stomach. And occasionally an ulcer perforations of duodenal wall, permitting the contents to enter the peritoneal cavity and causing peritonitis. Duodenal ulcer is 3 times more common than the gastric ulcers. Duodenal ulcer may erode the pancreas or gastroduodenal artery, causing burning and cramping epigastric pain. So that was about the duodenal ulcer. Let us understand what is duodenal cap. In barium meal procedure, after intake of contrast, the first part of duodenum becomes visible in the radiograph as a triangular shadow called as duodenal cap, and is emptied to jejunum every 1 minute. So, duodenal cap is a characteristic feature which we observe in radiographs. So, this completes the normal anatomy, histology and also the clinical aspects of duodenum. Thank you.